Okay. There, we got the screen?
Yes.
All right, perfect. All right, great stuff. All right. So welcome, guys. Thank you for taking the time to, refresh our knowledge on things that we see, quite regularly in our practices. So to start off with, we'll start off with some basic anatomy here. So we'll start off from the beginning here. So essentially, we'll start off with the first part here. Just grab that. There we go. So we'll start off with all the parts that can obviously get infected. We'll start off with the eyelid itself. We'll come to that. That'll be some blepharitis there. Then you have a reflection that comes in and covers the entire eye called the conjunctiva. That's, remember, the clear part of the eye itself. Just behind that, you're going to get the cornea, which is another clear layer of the eye itself. And then behind that, you're going to have the first space, all right, which is basically now your humor. And then behind that there, you're going to get the iris, which is the colored part of the eye. And then we're going to have the lens just behind that. And that's held in by two muscles, all right, on either side called the ciliary bodies. And that there joins up to the choroid, which is basically now your blood supply of the eye itself. Moving to the back, then obviously the most internal part here is called the retina, and that's the part that your body uses with its rods and cones to actually visualize and interpret the light signals. And then obviously now this is where the light actually cascades into the macula inside the eye itself, joining up with the optic nerve, and that goes obviously towards the brain itself. Now, the first thing that we'll actually now discuss is conjunctivitis. So remember, there's three types of conjunctivitis. The first one will be bacterial conjunctivitis. You're going to get viral conjunctivitis, or an inflammation of the clear layer of the eye. And then you're also going to have allergic conjunctivitis as well. We'll start off first with the bacterial conjunctivitis, the presentation. So the patient will come in with a reddish pink tint to the eyes, a watery or a purulent discharge, some itchiness. They're usually rubbing their eyes when they're coming in to see you, tearing a lot, together with the eyelids stuck together in the morning. If the purulent discharge is quite severe, you can actually treat that there with the topical antibiotics or ointments if it's quite mild. And usually you'll recommend to the patients that they go on treatment for about 7 days, despite improvement, because remember, this is can be spread quite easily. You touch a door handle, you touch your eye, and that's how you're going to get to the bacterial conjunctivitis. We'll reserve the oral antibiotics only if the situation is quite severe. Viral conjunctivitis is different, as it doesn't contain a purulent discharge. There's usually a clear type of a discharge together with the red eye, and this one can also be rather painful. Remember, viruses we treat mainly symptomatically. We don't really use antibiotics, so we don't use antibiotics for viruses. You can cleanse the area with a warm damp cloth. And then, as I mentioned, symptomatic. So if it's itchy, then obviously you'll prescribe an antibiotic. And then if it's painful, analgesics, and that will usually settle down. It's nice to do a little kind of dye into the eye, your fluorescein dyes, so you can actually pick up a little kind of ulcerations and damage to the eye itself. But it's usually self-limiting. Within 7 days, it should actually settle down. The last one is allergic conjunctivitis. So this one here doesn't have any kind of real discharge as such. It will actually present with a little bit of wateriness to the eye itself and itchiness with the redness. Now, a trigger for, kind of thinking that it's allergic conjunctivitis versus the others is the patient will present with a history, of a seasonal variation. So they'll usually tell you, around kind of, the change in seasons, when it's a bit dusty in the environment. It usually happens around this time. And then there's usually also an environmental influence. So if it's not seasonal, then the patient will come in, and say, when I'm playing in the park, when they're exposed to grass or trees or that type of deal, then, they'll all of a sudden get a reddish, itchy type of an eye. And that we're just going to treat with topical antihistamine drops, usually kind of every 6 hours or so. If you find that alone is not actually working, I usually try to combine that there together with an oral antihistamine. And what I try to do with my patients is actually prevent the problem coming in. So if they said, at around kind of September, I start getting an itchy eye, it usually lasts for about a month or so, then I'll actually prescribe the antihistamine for that month, just to be taken every morning. And we should be fine with that, and everything should settle down. Next one is uveitis. So this a little bit of the anatomy here as well. So the uvea, remember, is essentially now the iris together with the pupil itself. So essentially now you get the iris there, and then it leads into the ciliary bodies, which actually hold onto the lens, and that actually changes the lens for close-up vision and distance vision. And then that there actually leads into the choroid, which, remember now, as we mentioned at the beginning, supplies blood to the eye itself. Now, when you have uveitis, the patient will present with a bit of a painful eye. Well, it can be rather painful, actually. Increased floaters. So these are these little kind of, they look like little worms that actually are in your field of vision, and they'll float around in your field of vision. When you look, then it will move left, move to the right. The floaters will move very slowly towards. These are little protein deposits in the actual humor itself of the eye. Remember the little fluid that actually presents there. They'll also have photophobia. As we know, photophobia is the fear of the lights, and obviously some blurred vision because the anterior part of the eye is actually being affected at that particular stage. Treatment for these things here. So it's usually topical. So if it's an infective driver behind the pathology, then obviously we'll use some topical antibiotics. Oral, obviously, if the infection is quite nasty. And then if it's quite inflamed, that reddish eye, quite irritable, quite painful, then we'll apply some topical steroids. Now, the caveat to using steroid therapy is that we can't use it for too long because it actually starts to thin out the cornea itself, which obviously we don't want as well. And then to keep the patient nice and comfy, the wearing of dark glasses there. The next one we'll talk about is ophthalmic herpes. Now, just like any kind of herpes infection or shingles, essentially, this one here particularly actually involves the ophthalmic distribution of the trigeminal nerve. So the trigeminal nerve is essentially the nerve itself that actually now supplies sensation to the front of the forehead itself and into the eye itself, rising up to the tip of the nose. Now, when we have this ophthalmic herpes, then they'll present with pain, and it's usually around one eye. So only one part of the nerve is actually affected there. There'll be redness, rash, and sores around the eyes and on the forehead, as you can see in this diagram over here. There's a lot of redness, there's a lot of rashes around here. Let me see if we can see a little vesicle here. So maybe this one here is the best one to actually show you. So if you see here, there's a little kind of a clear, full little bubble here. And this here will actually present initially, and then it will actually spread with clear little kind of bubbles all around the distribution of the nerve itself, until eventually it starts to actually explode, and it will crust up, forming a little scab in that particular area itself. As we mentioned, redness around the eye and the swelling and cloudiness of the cornea itself, or the clear layer of the eye in front. Now, the treatment for this over here is if there's no eye involvement, then you can actually use antiviral oral medication, your acyclovir, scanciclovir, famvir, etc., to actually now help the patient along. It's usually because it's a nerve type of an issue going on forward, then you can actually use nerve blockers like Lyrica, pregabalin, to actually help the patient along. In the old days, we used to use other type of drugs, but I think, pregabalin is quite readily available. So we can actually use that to actually assist with the nerve implications. But obviously, if the eye is actually involved and the patient is complaining of, disturbance in vision and so forth, we should actually promptly send them to the ophthalmologist, because that there is obviously an emergency. Keratitis, that's an inflammation of the cornea. So if we if we look at the clear layer of the eye itself, so remember the conjunctiva actually now surrounds the entire eye itself. The clear layer of the eye, it's basically now the front of the eye itself, we call the cornea, and that's basically now where keratitis actually is. In this diagram here, it's not really, it's a bit, looks a bit involved, but essentially what they've tried to do with this here is that they've actually tried to differentiate between two different types of pathology, one being a viral complication and the other one being a fungal infection of the cornea itself, where you can actually see a slight difference in the dust distribution of the scarring over the cornea itself, nicely, kind of circumscribed here. But here you can see with the fungus is actually starting to grow across the cornea itself. These guys will actually present with a very painful eye. They'll be tearing because obviously of the irritation of the eye itself, pain on opening and closing of the eyelids. So as your eyelid actually crosses over the clear layer of the eye itself, it will actually touch against the inflamed area, and that's how we actually get that pain. Loss of vision or blurred vision. Remember, the clear layer of the eye is clear for a reason, so it can actually reflect eye into the eye itself for interpretation. But if there's inflammation of the clear layer, it becomes cloudy and you'll have a loss of vision or blurred vision and some photophobia, fear of the lights again. Now, these ones here, these are the triggers to diagnosis. So when you're taking the history, you'll find that these patients are usually contact lens wearers. They immunocompromised patients, obviously our vast HIV population. Those that are taking immunosuppressants, I mentioned topical steroid use further along there, and eye injury, so penetrating eye injury with plants or chemicals. So if someone is working in the garden, they actually had a little scratch on their cornea, and that's how the infection got into the eye itself. The treatment for keratitis is usually according to the initial agent that caused the problem. So based on the distribution and some certain tests that we can do, that depends on the cause. So topical antibiotics or topical antifungal drops, quite bad. You can actually proceed to oral as well as topical management as well. Endophthalmitis, this is our next pathology. So this is an inflammation of the interior of the eye. The picture that we're actually seeing here, you can actually see that the cornea has become exceptionally cloudy. So the patient won't be able to see inside there. There's a little pus formation. So if you can see that there's a little fluid level just in the anterior chamber of the eye. And this is basically pus that's actually building up here. You can actually see the conjunctiva is actually super, super inflamed. You can't actually see the blood vessels that usually travel along the sclera or the white part of the eye. And this is super, super injected at the moment. So our patients will present with some photophobia, again, fear of the lights, blurred vision. As you've seen, the cloudiness of the eye will actually now lead to that there. Eye pain, quite severe because the entire eye is involved. And there's usually a history of some eye surgery penetrating the eye itself or a foreign body getting into the eye. It can present with a discharge as well. But obviously, because it's a global type of infection, the infection is throughout the entire eye itself. Now, this treatment is usually on an emergency type of basis because the entire eye is involved. So if you see this type of eye, then you're not even going to actually, examine the patient, too thoroughly and so forth. Time is of the essence. You're just going to say, listen, this here looks really, really bad. I think you need to go into the hospital and you need to go and see an ophthalmologist as soon as possible. The next one we see quite often, it's a blepharitis. It's a very technical term, but essentially now it's an inflammation of the eyelids itself. Here, the upper and the lower eyelid is actually involved. Very little in terms of the actual eyeball involvement at all. It's basically an external type of infection. As you can see, the eyelids are red, swollen, can be itchy at times. Now, the blepharitis treatment, usually we'll try with some warm saline cleansing. So I usually recommend to my patients, you get some gauze, not cotton wool, because cotton wool, remember, will break up into strands and that'll stick to the eye itself. And then we're going to have problems there with more foreign bodies into the eye, bringing in more infection. We're going to have some topical antibiotics in there. Our usual ones, fusidin, chloramphenicol ointments, etc., over the 7-day period until it settles down. And again, oral antibiotics we can add on if it is rather severe. Hordeolum, this here is a bread and butter, type of thing. It's an infected hair follicle along the eyelid margin. Right here, you can actually see here, there's a little kind of tiny abscess type of formation along the eye itself. You can actually see a little head of the abscess itself, but we usually find it on the eyelid margin where you'll see a little kind of a white spot, just where the pus is actually trying to drain up and where the hair follicle actually fell off. And that's how the bacteria got entry into the body itself. You guys will actually present with a pimple-like bump on the eyelid margin, as you can see there. It can sometimes be presenting with a bit of pus discharge from that particular area, but not always, together with that, like I said, a little bit of a lump or abscess formation in that particular area. The treatment of these here, you can use some saline cleansers, again, with some gauze to the edge of the eyelid itself along the margin. So I try to get my patient to do that every kind of 4 to 6 hours. Just even if you can't get saline in the pharmacy, you can actually get or make up your own saline solution and start cleansing the eye itself. And that usually resolves quite easily on its own. If there's associated blepharitis or an inflammation and infection of the eyelid itself, you can continue with your topical antibiotics there. And oral, obviously, if it's quite bad as well. I've mentioned the Johnson & Johnson baby shampoo. Remember, that is a no tears formulation. So if the patient can't access saline or it's a little too confusing for them to actually mix up a saline solution, then you can actually recommend just a little bit of Johnson & Johnson in a glass of water and use that on the lid margin itself. It won't actually affect the eye itself. But obviously the caveat to that is if it starts irritating the eye and if the patient actually gets too much into the eye, then it can irritate the eye. But I find that it works very, very well, especially for those individuals who present with recurrent type of hordeolums or styes going forward. Then at least on a kind of a bi-weekly basis, just get them to just kind of cleanse the eyelid margin itself. So the eyelid hair doesn't actually get blocked in the first place. Right, and that's been the presentation. So if there's any questions and so forth, we'll take those. But hopefully you guys are a little more adept now at actually now looking at these, knowing when there's an emergency, when there's not an emergency, and a little bit about the treatment modalities that are available to us. Any questions, guys?
Just remember that everybody is muted. Thank you very much, Dr. Nathaniel, for that very interesting presentation. So any questions, just unmute yourself. Feel free to shoot. So we only have like 4 minutes left as well.
Thanks, Nathaniel. That's actually a very nice use case, especially in the telehealth environment. Just want to check with you, the case that you particularly seen, did you have good visualization or good images to go about?
So, yeah, no, the thing is that I think we should actually move the iPads around and try to get, better focus of the areas that are involved, not particularly only, because we're looking at the eye today, but for any kind of lesion, we should actually try and get, kind of still pictures if we can. I'm not sure if the guys are trained on taking, kind of high resolution pictures, but it will definitely help with our diagnosis going forward. So, to answer your question there, I haven't really gotten some good visualization of these. I'll try together with the history to actually now try and get, the best diagnosis we can. But as long as we exclude kind of emergency cases, I think we're in a good space when it comes to telemedicine.
Okay, no, 100%. Thanks. Yeah, thanks for that. So I just want to encourage the nurses out there, if they do see cases like this, try to get good quality images. I think that will speed up the consultation as well, and just gather proper data for these type of scenarios. And I think it will help with in the right diagnosis and outcome.
Yeah, no, great stuff. So if on that point, if anybody is a little bit unfamiliar on how to use the camera on the iPad to take photos and such and upload it within the consultation, feel free to give us a call or email. That we can do a session again and just show you exactly how to go about. It will be put on the iPad that says how to UDoc, that step-by-step instructions will be, training will be on there as well. Yeah, so is there any questions regarding this presentation or any other questions?
How are you?
Yeah, very well.
Good, man.
I'm great. Hi, Dr. Nathan. How are you?
Hey, good, man. What's up?
I'm great. You're speaking to Austin here in Santon. I wanted to know the basically conjunctivitis is pink eye, right?
Yes, yes. The colloquial term for that
Oh,
eye. Yeah, exactly. So remember, because of the injection of the eye itself, where the blood vessels actually start to swell up in response to the infection itself, the eye tends to have that pinkish type of hue to it. So that's why we, the common man will actually call it pink eye, going
so
forward.
why
But
is it?
as
So even,
yeah.
Sorry to
Right.
interrupt. So basically even conjunctivitis is also infectious, if I
So
put it that way.
as we've mentioned in the talk, there's three common types that you're going to be seeing. The two of them are infective, so you can get a bacterial infection where you get the pus discharge. You get a viral infection where it's kind of a clear type of a discharge. And the last one is allergic conjunctivitis, where there's no infection involved, but it's in response to pollen, cat fur, dog fur, whatever the patient is actually allergic to. The patient will present with that itchy eye, usually no discharge or a very mild wateriness of the eye itself. And that's how you're going to differentiate. So it's going to be history of the patient itself and their presentation that will differentiate now, which is, kind of the infective one and which allergic one going forward.
Okay, I get you said things like signs and symptoms, but how do we define if this one is allergic and this one is not allergic, since they present the same, similar in a way?
Yeah, so the examination will be kind of similar, where you'll see a reddish type of an eye. So in a viral situation, in an allergic situation,